So I think one of the things that we lack these days, and when you go through dental school, you get taught all this sort of stuff. And sometimes when we get into practice, we forget all of this. History taking, clinical examination, provisional diagnosis and tests, etc. So I just want to run over that. And there seems to be also a trend towards a lack of documentation in the notes and that sort of thing. So when it comes to medical legal issues, if it's not in your notes, it's not there, it never happened. And so if you want to be able to defend yourself if you ever have problems, and sometimes they're not even complications, sometimes patients just complain about us because they feel that they need to do that for some reason. So I think documentation is important. So I'm just going to run over this really because I think these sorts are important things. So when I take my notes, I have all these things down in my notes. I just go through that and have headings and make comments on all of those things as we go through, which is important. And then if we're ever questioned about anything, or if we ever want to look back in their medical history or whatever, it's right there in our notes and it's documented and it's clear. Is the other thing as well. And so we forget also some of the other things, as we get busy in practice and we rely on special tests, we rely on x-rays or cone beams or CTs and things like that. But basically we're clinicians and our first thing is an inspection of the patient. And we can palpate. So if there's some infection, is it infection? Is it a tumour? What is it? And so we can palpate the face and intraorally and get some idea from that. Percussion testing. So, still use that. If we've got ankylosed teeth, for example, I use percussion testing just to check on those. And see if they can make some assessment in the clinic. If it's a primary tooth and we're percussing and it's a dull, it's probably ankylosed. It's submerged, then we're suspicious that it's ankylosed as well. And that might change the way we approach this, how we're going to extract it, or whether we're going to do it under local anaesthetic, or whether we may choose sedation or a general anaesthetic, depending on that. So we make a provisional diagnosis first. So we go through that, and then sometimes we might need some special tests. And in dentistry we use radiographs a fair bit, but there may be some question about bleeding. And I pick up about 10 people a year who've got undiagnosed von Willebrand's just by the history of them saying, oh yes, I bleed a little bit, I cut myself, or I had some surgery and I bled a fair bit, and they had trouble controlling that, or their parents had some bleeding conditions, and so we send quite a lot of people off for tests before they have major surgery, and we do pick up at least 10 a year undiagnosed, and they had significant issues. And I think this year there was a death after a tooth extraction, and I'm not exactly sure about all the details of that. There are other medical issues with that as well. And histology, that's important. Remember when I was in the UK, one of the consultants telling me about they'd taken out a lateral incisor, you created what they thought was a granuloma, and they thought, well, they'll send it off for histopathology, and it came back as a squamous cell carcinoma. So there are cases like that when we will correct things, we'll think it's not relevant tissue, throw it away. So pretty much, if you biopsy something or you take off a lump or bump in the mouth, then you've got to send it for histological examination, and that's the appropriate thing to do. And I think not all of us do that all of the time. And bacteriology. And again, when we've got severe infections, it's easy just to prescribe some antibiotics, but if you've got some pus there, it's a good idea to swab it and send it off, because you will get the occasional infection that's difficult to control. And if we don't have any bacteriology on that, then we can't manage that appropriately. So we have a definitive diagnosis and then treatment plan. So once we've formulated that, then it's our prerogative to be able to explain to the patient what they need to have done. What are the consequences of having it done, what are the consequences of not having it done, and what the expected outcome of the treatment is, and what the particular complications of that. And I think probably in dentistry we do that pretty well. I deal with a lot of medical people as well, and you go for consultations with them, and often they explain very little. So I think generally the dental profession is pretty good at explaining these things, but if you don't, then it's a problem. And if your patient comes back and says, I'm swollen, I've got this, or I've got some nerve issues or whatever that, if you didn't explain it, then that's a potential problem and a source of potential litigation. So before we engage on treatment, we must make some decision. Is the patient appropriate for local anaesthetic, for example, or whether they need some sedation or general anaesthesia? Can we do the procedure? That's another important issue. And do we have the skill set to be able to perform the procedure is important. And then if we've taken a good medical history, then we can make an assessment of whether they need some antibiotic prophylaxis, And are they taking anticoagulants? And years ago, you could remember all the usual drugs that people were on, all the hypertensive medications or anticoagulants, and now there's a whole range of different medications and drugs out there, and it's difficult to keep control of all those. And I often look stuff up, we Google stuff a lot on drugs that we don't know about. So there's quite a lot of anticoagulants and you can get caught out with those sorts of things. So I just wanted to briefly run over those issues because I think they're important things to look at, and I think we fall short a lot of the time in our documentation of all those sorts of things. And the insurance companies are going to be hot on that. And if you don't have documentation, you will be criticised for those issues. So if we have a look at this when extracting teeth, we just want to have a look at the relationship here to the maxillary sinuses. So the upper first molars will often project right into the sinus, and we have a look here. Here's the sinus floor running through here, and these teeth are popping into there. So when I see this, I always say to the patient, the roots of your tooth are sitting in the sinus, and when we extract this, on some occasions there will be a communication there that might need closure, and then I explain what that closure means. And if we extract the tooth cleanly and it's a simple extraction, there's not going to be much discomfort with that. But if you raise a buccal flap and advance that over that tooth socket, they're going to have significant swelling. So there's a significant difference in the outcome of the patient. And there's a significant difference where maybe they're going to go back to work the next day. But if you close an oral antral communication, well, maybe they're not going to go to work for quite a few days afterwards. So that impacts on them as well. And then there's all the social things that go on. People come in, they have a tooth out, and they might be expecting to go out for dinner, go to the footy, go wherever else, and then they can't do that because you did a procedure on them that you didn't explain it fully of what the potential side effects or complications are. And so, that's probably the most common tooth to have a communication. Usually the roots of the second molar are covered, and we can see in this particular case we've got bone right up to here, but we've got the roots of the first molars projecting into the sinus. Okay, here's another case. Have a look, we've got a root filled upper 7, and there's a radiolucency around the apex of that. So when we assess this, the roots may be below the maxillary sinus, but we may have some pathology, such as this case here, where there's no bone on the floor of the sinus here. So when we extract this tooth and curate that area, the likelihood is that we are going to have a communication through to the sinus. So I know that before I start, and I explain that to the patient before I start. So the assessment of our radiographs is really, really important, and that's what we as dentists are trained to do. So depending on which radiologist you use, you may get a very poor report lacking in information from the radiologist, or if you send it to Perth Radiology or Envision, you might get a really good report because they've got some maxillofacial radiologists there. But we are all trained in that, and we should be very good at making a diagnosis. Here's another case, extractions that are required for orthodontic purposes, and again, the roots are projecting right up into here, and quite often what you see is the sinus floor dipping down between the roots and go up. So when you extract a tooth like this, not only can you have communication where the roots are, but all of this thin bone actually may come with the roots, leaving a communication through into the sinus. And again, if we have a look at the other side, the same thing, the roots are right into the sinus floor. Okay, so here we go. I've extracted these teeth, and we can see what we've got here. There's not complete root development on those, and they were extracted in toto. So I always inspect the roots to see. Quite often we see cases where they retain roots within the jaws, and it's really important when you extract a tooth to inspect the roots. If there's a fracture there, then we need to make an assessment on whether it's viable to remove the root. So sometimes when we chase a root like this, we may actually, when pushing on it, push it into the sinus and make the situation worse. And there's a difference between extracting a vital tooth and a non-vital tooth. If we have a small root apex on a vital tooth and it's close to the sinus, we may make an educated decision that it's best to leave it there rather than chase it. If it's an infected tooth, then we need to remove it, because if you leave that there, it will continue to be a source of infection for the patient. So what do I like to use? So I usually use periotomes, and we may use other type of elevators to mobilize the teeth first. And for upper molars, I like to use the hawksbill forceps. I find they really fit the shape of the teeth. They're very well designed. Everybody's got different favorites, but they are my favorites for that. Extraction of primary teeth. Now, these can be some of the most difficult teeth that you'll ever extract. If they're submerged and ankylosed and they still have root structure there, then they may be difficult to remove. So I always explain when we see a situation like this, we can see it submerged, and quite often these other teeth have drifted over the top of it, so we know we're not going to be able to extract that tooth because the space is narrower than the tooth. And there's some nasty things that can happen when you're extracting a tooth like that. It may be you put significant pressure on the premolar. Premolar root is nice and conical shaped, and you can pop this tooth out while extracting that one, or chip this one, or if you've got a crown or whatever next to that, it may be possible to displace the crown. So being careful with those. So here I am, I've extracted the crown of that tooth, but if we look here, there's still a retained root in there. Now that root's ankylosed, and so again I'd use something like a periotome around that. I want to conserve bone in the area. If it's an orthodontic extraction, like this situation, then they want to move the molar teeth forward into the space. We need to have some bone there, or if it's a case where you're extracting and you're considering an implant, we don't want to remove a lot of bone. So I tend to remove if I'm going to drill it all, I'll remove the interradicular bone because I know the socket's still going to fill in that area, but I don't want to remove buccal bone or palatal bone or lingual bone in those particular cases. And it's important to remove all the root structure. We do see quite a number of radiographs where primary teeth roots still remain. So I think what happens quite a bit is people extract the crown and just assume that the roots will just resorb away, but they don't resorb away in a lot of cases, and that can actually affect orthodontic movement. So if we want to move this tooth into that space and we've got a retained primary tooth there, that can affect the tooth movement into those areas. So again, this is an interesting tool, just a root apical pick, and I use those on occasions while they can be very useful as well as periotomes for getting into narrow, tight spaces. So here's that tooth, so that's that root apical. So we've got the tooth and I've got my apical root tip in here, and I've been able to mobilize that without doing any damage to the adjacent teeth. And also with the primary teeth, often the sinus is pneumatized in those areas there, so often there's very little bone between the roots of these teeth and the sinus. Very easy to penetrate the sinus, push the root into the sinus, or push your instrument into the sinus and create a communication where there wasn't. So being careful in these situations is very important. And then, as I said, I like to inspect the tooth. So here's the extracted tooth, and here's the fractured portion here, and I put that on there and I have a look at those. And also, if you inspect primary teeth, you can see what looks like a resorption, an area of root resorption looks different from an area of root fracture. And so inspection of the root is important. And we want to see all of that in the end. Now, if we move on from maxillary teeth to mandibular teeth, again, I like to use the hawksbill forceps, or if we've got a crown missing, we can often use these cow horns to remove the remaining root structure there. So I will try a lot of the time to extract teeth with forceps rather than straight going to a surgical removal. If it's not simple forceps extraction, then I'll go to a surgical procedure fairly quickly with that. And particularly with lower first molars where they've been root filled, they can be quite brittle, and you do get the cases where it doesn't matter what you do with an elevator or whatever, you end up having the tooth chip, significant chipping all the way to the apex, and that's when I'll drill through the interradicular bone quite a way. Obviously you're making an assessment how deep the nerve is, and then elevate once I've removed quite a bit of bone centrally within the socket, not the buccal or not the lingual walls. So we need to know the most important thing that we're going to encounter in the mandible is obviously the infraalveolar nerve, and we want to avoid damage to that at all costs. So we're going to use radiographs, and now I use cone beam radiographs quite a bit when looking at molar teeth. So if we have a look at this case, these teeth are not fully developed. We see this tooth is right over the mental foramen, so it becomes difficult to tell where the tooth is and where the foramen is, and then these teeth are sitting right along the infraalveolar nerve. And if we have a look with a bit more root development, we can see that the apex of this tooth is curved and it's right against the mental foramen here. So if we do a simple forceps extraction of that and rotate that, there's a potential that will rotate the end of the root into the mental foramen and damage the nerve that way. And then these teeth are right down against the infraalveolar nerve. So we've got to make some careful assessment when extracting teeth like that, and whether it's going to be a risk. So you might choose to section that tooth, that molar tooth, rather than do a rotational movement where you've got the potential of squashing the infraalveolar nerve. So our 3D cone beams or CTs will tell us that. So if we have a look at this, then we can see the roots down here, right next to the nerve. So the nerves between the cortex and the root. So if we go and do some buccal lingual movement to mobilize this tooth, or we do a figure of 8 movement, we're going to squash that nerve, and we're going to have some potential nerve problems. So making these assessments is really important, and we may choose therefore to have a different approach with sectioning a tooth to remove something like that. And again, this is the other side, and so we can see the same relationship where we've got a root here on this side, we've got a root on that side, the nerves in the middle. In my career, I've seen 3 molars now where the nerve passed between the roots, completely between the roots. The roots had fused underneath the nerve. So in that particular case, if you're not sectioning that tooth, you're probably going to avulse the nerve with extraction of those teeth. So assessment's important, and then we can have a surgical approach appropriate to remove the tooth without damaging that nerve. And this is that tooth removed. So we can see there's actually 4 roots on the molars, 2 here and 2 fused here. And then that was the relationship with you can see the groove on this tooth is where the nerve was sitting against that root there. So this was removed. There was no paresthesia, no nerve damage with this appropriate assessment and choice of how to remove that tooth. With this particular case, is a root-filled tooth. There's fairly conical roots on this, and there's significant pathology associated with this. So not only we've got apical problems here, but we're looking at starting to get some, lack of bone next to there. So leaving a tooth too long, holding on to tooth too long, starts to affect the adjacent bone heights. And if we want to put implants into these sites, then we want to remove these teeth early. We want to conserve as much bone so we have a good bone housing for putting implants into. So the implant game changed everything. When we surgically removed teeth before, people were quite happy to remove the buccal bone, made it really easy to get these teeth out. So it's a little bit more complicated to remove teeth now, where we're really concerned about maintaining as much bone as possible. Okay, so here's a periotome we use for taking out molar teeth. It's quite difficult to use a straight one in the molar region, so they're angled for that, and we've got some significant pathology here. So we've got an abscess. We know already that we've got a buccal abscess that's perforated the buccal plate, so we've already got some bone loss on this particular tooth, and we want to remove all the pathology. And there are cases where people extract teeth when they've got apical pathology and don't bother correcting the bone. So you must correct all the pathology out of the sockets, and that doesn't always happen. And I get referrals where you see where people have left pathology there and the sockets heal poorly, and then we've got to go in and correct those areas again before we can get some decent healing to put implants into. So just to show what I do with these, I pretty much use periotomes for all of the extractions. Particularly in older people, the bone will be brittle, it'll be difficult to take the teeth out. Sometimes there'll be parts of ankylosis of roots to the bone, and we may actually tear out chunks of bone when we extract teeth, and we don't want to do that these days, so we can get in and really expand that socket a little bit beforehand. Once we've done that, we can get our favourite forceps and extract the tooth, being mindful that we're going to need to remove that area of pathology as well. So here's the tooth coming out, and then we inspect the roots to make sure that they're all there. Otherwise we've got to go in and remove the remaining bits of root that are left there, and then we use curettes and thoroughly curette the sockets and get in there, and then we can curette that infected area there and to remove all of that as well. And then we'll get good blood clot in there, and then we'll get good bone healing in there. And we want to see all of those little bits of pathology removed from the sockets. And then, some a bit inherent there. You can use artery forceps and those sorts of things to make it easier. And quite often in these areas you've got some soft tissue pathology along the ridge here, and quite often just under there might be bone loss as well. And so underneath this ridge of bone that you have there, those areas are really difficult to thoroughly correct, and it takes some time to do that. Okay, so what I thought we'd do now is just show a few videos of how to approach different teeth. This is the third molars in this particular case, so we may have just a soft tissue impaction here, and we can use a simple elevator. So this is probably the simplest removal of a partially erupted tooth that we'll see. And